what's exciting about this panel up here is these are the folks that are making it happen within our state. And what we're going to be sharing here are examples of what's happening in the state of Michigan around consumer engagement. And I think Cynthia said earlier this morning that, you know, everybody in this room has some kind of personal passion, personal experience with the healthcare market. And, you know, my stories aren't as poignant as Aaron's or Sean's or Lieutenant Governor Kelly's this morning, but, you know, even in my family in the past decade, we've kind of rotated who is the primary consumer, who's the highest utilizer. I mean, just my wife's pregnancy, our children going through kind of infancy and early childhood, and now my mom kind of, you know, working through the same above the neck and below the neck challenges that I think Cynthia and others have talked about as folks get older. And you know, what's great here is we've got the folks in our state. You know, I'm a consumer too. We're all consumers in the state of Michigan. Well, folks that are not from out of state joining us, but all the folks here, you know, these folks are on the ground. They're actually the ones that are going to be sharing with us today those successes and those challenges in engaging the patients, the beneficiaries, the underserved across our state. So I'm going to kick us off with a quick video, and the video is entitled "Your Health is in Your Hands." It's a whiteboard animation video introducing consumers to the concept of Michigan's forthcoming statewide consumer directory, which patients can use to manage where their health data resides and who has access to their health information. So I think George was saying earlier, you know, same thing with the consumer directory. It's not another portal. Really what the consumer directory is built to do is to help patients designate where their health information is stored, indicate the location of personal consent documents, including advanced directives, and consent to other use cases, such as clinical trials that were discussed earlier today. Specify preferences for sharing their personal health information, and really it's also the flip side. It's enabling the providers the ability to go find where that information is as they help care for the patients, such as the advanced directives. So why don't we go ahead and cue that video.
Good healthcare centers on clear communication. Patients tell their story to a doctor who listens closely, reads symptoms, provides solutions, and records the results to help define the plan for your best health. A strong patient-doctor relationship is the foundation of effective healthcare, and a story that ends with the best possible outcome. But in the complex world of modern healthcare, there are multiple actors who also play key parts in helping a person remain healthy. What starts with patient A meeting Dr. B soon grows to include pharmacist C to have a prescription filled. Easy as ABC. Until patient A is taken to the emergency room of Hospital H because of an accident and is then referred to Specialist Z. Hospital H doesn't have patient A's health history from Dr. B on hand. Specialist Z needs that information to properly assess whether medicine M can be given to patient A without causing interactions with other medications or an allergic reaction. B and C know that A is actually allergic to medicine M, but they don't know patient A is being treated by Hospital H. Patient A's psychologist P at Clinic Q knows that patient A also takes medicine for depression that could have interactions with medicine M, but is unaware that patient A went to the emergency room. Dr. B may not even know that patient A left the hospital, and often by this stage, not even patient A has a good understanding of the whole story. This process not only leads to confusion, but also danger. Patients need their healthcare providers to be notified of significant and potentially life-threatening changes to the care plan or medication profile to coordinate efforts and ensure proper safety and optimal care. Thankfully, people in Michigan will no longer have to play broken telephone with healthcare providers and medical service professionals who need to stay abreast of a patient's vital medical history. Keeping the story straight and ensuring everyone stays informed is being made possible by using Michigan's statewide consumer directory. The consumer directory allows people to ensure their health data is shared the way they choose. Starting by simply creating a secure profile and password to join the directory, consumers will be able to select who from their care team, doctors, care coordinators, specialists, guardians and custodians, or emergency contacts, can receive critical alerts and access the right health information in the right place at the right time. Consumers can specify where to find or where to send their health details, such as a personal health record, like Microsoft's Health Vault, Michigan's MyHealth Portal, No More Clipboard, or Humetrics. The Consumer Directory also stores locations where important instructions for any future medical situations are kept, including living wills, organ donor registration, or do not resuscitate instructions. This helps make a patient's information and personal preferences available to medical practitioners, even if the patient is unable to communicate. The statewide Consumer Directory also allows consumers to set preferences for participation in a growing number of healthcare data sharing options, giving patients control over their privacy and security by deciding who has the right to read their healthcare story and specifying who can share and add to it as their story grows and changes. Michigan's Consumer Directory means necessary information from A to Z is shared one way, your way. The Consumer Directory allows those who have an active care relationship with you to easily collaborate and stay up to date on important health events if you choose to allow them. Using the directory will be as easy as using your mobile phone. Visit www.mihin.org/consumers to learn more about the Consumer Directory today and get a better read on how you can take control of your healthcare records. In Michigan, your health is in your hands. Collaborate and stay up to date on important health events if you choose to allow them. Using the directory will be as easy as using your mobile phone. Visit www.mihin.org/consumers to learn more about the Consumer Directory today and get a better read on how you can take control of your healthcare records. In Michigan, your health is in your hands.
All right, everybody follow the alphabet diagram at the beginning? There's no quiz later. I don't think I could have. So I'll introduce all of our panelists to begin with in the interest of time, since we do have 4 panelists and I'd like to give them all time to present as well as have time for questions at the end. So leading us off will be Krischa Winright. She's the CIO of Priority Health and a VP at Spectrum Health. She leads teams focused on digital, web, and mobile development, as well as business applications, informatics, portfolio management, and architecture. So a very talented individual, leading some talented teams, and they're doing some very innovative things over at Priority and Spectrum for their members and patients. So we're also privileged that she shares those talents with the MiHIN board. So thank you, Krischa. Next will be Barbara Bloom-Alexander, who's a program manager, Office of Community Health, Equity and Wellness at Henry Ford Health System. And Barbara started working with the Generation with Promise program while she was at MDCH, back when it was MDCH, and she's continued that at Henry Ford Health System. She has over 20 years in the field of public health and social work, primarily in Detroit and the surrounding communities. Thanks, Barbara. And next up will be Mita Kreiner, who is a senior quality analyst with Medicaid Care Management and Quality Assurance at MDHHS. She played a lead role in developing the Healthy Michigan Health Risk Assessment, or HRA, that we've heard about kind of throughout the past 2 days, starting yesterday with some of our keynote speakers. And she's worked on, since then, blending that into the Medicaid member portal, which we'll see a little bit about later, so that the Medicaid beneficiaries can complete their sections of the health risk assessment. And then on the back end, once the sections are all completed by the providers and by the payers and submitted back to the state of Michigan, they get to view what their health goals are and kind of track those goals throughout the year. And finally, Ryan Sullivan is the policy director for Michigan Consumers for Healthcare, where he coordinates policy and advocacy activities and represents consumer coalitions at the state and national level. Ryan also has a bachelor's at U of M, master's at University of Texas, law degree at University of Houston, so we're glad he took time out of his academic adventures to help us at the state of Michigan with the consumers. So I'll kick it off with Krischa. Thank you. Please welcome all of our panelists. Thank you.
Thank you. When you went through the alphabet discussion, I was thinking it was very similar to the old who's on first discussion, which my kids shared with me thinking it was brand new the other day, by the way. So thank you for having me today. What I'm going to be talking about is the experience the Spectrum Health and Priority Health have had in connecting our consumer experience. For those of you that are not very familiar with our system, we have 3 major entities within the Spectrum Health system: the hospital group, over 13 hospitals, a 1,200 plus multi-specialty physician group, and then lastly a health plan. Has about 650,000 lives in the state of Michigan. So that gives us a really nice opportunity to try to break down some of these interoperability barriers and to say, okay, how do we think about that within a large integrated health system? So I'm going to show you a couple of examples of the innovation that we've done in this space, but I kind of wanted to break the quick talk into a few different areas. First of all, what opportunities do we have when we combine payer and provider information? We're certainly doing that every day. Secondly, how are we overcoming some of those interoperability hurdles within that environment? You know, we've heard a lot about that, you know, today and even yesterday relative to, you know, where are we going as the state of Michigan to open up the interoperability across health records? But that really starts in our own backyard to say, hey, if we don't even do that for our own space, how are we ever going to get to that future? So we're certainly doing that work in our environment. And then lastly, I'll give you an example of a tool that we just developed and launched in January that's a good example of that. So this was an example that, you know, it's certainly a dated screenshot from several years ago when we started embarking on what would our connected patient and member experience look like in our environment. So in all fairness to this organization, that's not where they are today. But when we started our this has really been an anchor for us in the environment that they were in. You know, they had a EHR patient portal. They had another patient portal if you were with their medical group. It gets kind of humorous if you can read the small print. You know, if you're a patient at this, log in here. If you're a patient here, log in here. And then I love the bottom line, still not sure which patient portal to use. Click here. And we said, you know, that didn't define who Spectrum Health was, certainly. But I think, you know, the sobering reality is even as we are working really hard to solve that for our patients and members that have anything in any relationship with the Spectrum Health system, the sobering reality that we're here to discuss, you know, this week is even though I would do that for my environment, a patient still has perhaps several of these experiences that they have to log in and do that connecting point themselves. So that really serves as our true north for the work that we're trying to do. How do you make that obviously easy for the patient and consumer? So what did we do within the Spectrum Health enterprise? We've been on about a 36-month journey to connect for our patients and members in one location, all of the information that they might need to manage their relationship and indeed their medical information, clinical information, insurance information in one place. We created that, and the really heavy lifting was how we broke the interoperability barriers down underneath the covers. We have 2 electronic medical records in our environment, plus obviously all of the types of information that go along with a health payer, you know, claims payment, care management. This thing connects to, you know, probably 12 different back-end sources of truth that we integrated via a web services layer and are able to then deliver to our patients in a really easy-to-use interface that's mobile. And so that's an example of, certainly for us, it represents the single integrated digital experience for Spectrum Health and Priority Health. We do at present have over 300,000 individuals digitally connected, and that grows by thousands each week as they have a new, you know, again, a relationship with our organization as we're redefining how we engage with members and patients. So in that experience, you can see results, obviously clinical results, your lab results, radiology results, integrated care management. As you've seen in several of the solutions that are even being presented, that's non-trivial, right? How many locations are there to store a care plan? We struggle with that in our environment, and indeed, you know, certainly want to give the patient one point of contact from a care management perspective. But it gets even more interesting for large enterprises. We talk about the clinical side, but increasingly patients are bearing more and more of the financial burden that goes along with the healthcare equation. And in our environment, to be able to even provide something like integrated billing and payment, a single line of sight to every financial obligation you might have around your health care, whether that be your premium, whether that be, you know, a bill that you have due to a medical physician, a hospital bill. How do I manage, what we would call even in the future a digital wallet that can help me manage those costs and have transparency to them? Those are the types of things that we have to grapple with in our environment. You could argue those are more administrative. In about any other industry, billing and payment is not administrative, right? There's a whole experience around that. And so we've got a ways to go in healthcare, and we're working diligently on that piece of it. E-visits, rolling out new solutions for telehealth and telemedicine. We used to, in our environment, leverage vendors for that. But there again, it's a point one-off solution. In our environment, it's much easier for a patient to authenticate. All their clinical record is there. They can have an e-visit with their physician or someone in our medical group. It's all in the EMR. It's the appointment scheduled. It's on your timeline within the MyHealth experience. That's kind of where we're headed. We'll show you the cost estimator tool and talk a little bit more about the financial obligation. But I think the thing that we would want to get across and what we're working on now relative to this digital experience is, okay, now that we've gotten that resolved for certain big areas within our Spectrum Health environment, how do we now start leveraging and driving statewide services that can do that even more elegantly on a broader level? I'll use the example of a digital wallet. Okay, that's not the clinical information, but boy, wouldn't it be great for you to not have to, when your credit card gets stolen, re-enter that in every healthcare environment that you need to, and enter it in. So that's an example where now that we've abstracted and created interoperability within our own environment, we have a lot more options. We can now leverage MiHIN to build some of those services. We can work with the state of Michigan to consume and publish services that are more statewide, that are more near the patient and near their critical service. So I guess, if to end the session around, interoperability, I would encourage each of you, not to expect a brand new vendor to solve all those problems for you, but instead to, do the work that we need to do within our own environments to federate this information and make it available. So that's one of the things that we're working on. This is an example of the landing page of our experience, and I put 3 screenshots up here to show you that this is the type of flexibility patients and members in our environment expect. The experience on the left would be what you would see if you only had a relationship with our environment around the delivery of care. So, maybe you are a Blue Cross Blue Shield member and you're with a different payer, but you have come to Spectrum Health to seek services. You'll just see the clinical side of that environment. Whereas on the far right, let's say you're one of our members, you're insured by Priority Health over on the east side of the state and you're leveraging a different delivery system. We recognize your relationship with our environment and we flex your experience accordingly. The experience in the middle, however, is much more robust. And the patients and families that use an integrated experience, what we're finding is it's so much richer. When we can put claims, payer, provider information together and engage you around healthcare in general in one location, the engagement rates go up. And so that is, certainly what we're learning in our environment and a lesson for all of us, that the more we work together on, statewide interoperability, we will see engagement of members and patients and consumers increase if we're really not fracturing that just by the work that we're doing. So here's an example of something that we rolled out in our environment as, a perfect example of the intersection of care and cost. We decided to start working on behalf of our members at Priority Health and showcase that there is differences in cost and quality in our market and making that transparent. Priority Health is a firm believer in the transparency of healthcare and working hard to make that a reality for our members. So we rolled out this tool that basically you can enter a procedure. We've got over 300 shoppable procedures out there. You can enter a provider in a facility and it will show you quality information. It will also compare that cost to the fair market price and be able to show the member exactly what they would owe out of pocket. This is just one example of many, but that allows a patient to engage around the whole of the equation: cost, quality, and the receipt of care. So anyway, in short, that's what Spectrum Health is doing to break down the barriers of interoperability and increase the value for patients and members. And we look forward to all of your hard work and participation in that as well. Thank you.
There's a few key differences between myself and our first speaker. One is height. Another is that I'm going to be talking about not patients, but actually participants or community members in ways that we engage them to promote community health or population health. So my name is Barbara Bloom Alexander, and I'm with Henry Ford Health System in Detroit. I'm pinch hitting for Dr. Kimberly Dawn Wisdom, who's our Senior Vice President of Community Health and Equity, our Chief Wellness and Chief Diversity Officer, and our former State Surgeon General. So we have a department that's actually run by Dr. Wisdom called Community Health, Equity, and Wellness, or CHEW for short. And we have many different initiatives where we engage community members, underserved community members in Detroit. And I'm going to talk about two today where we use technology. The first one is called Sew Up the Safety Net. And I'm supposed to advance the slides. This was our original goal statement. I'm not going to read it for you. But we developed a task force around infant mortality in 2008, and Nancy Schlichting, who is our CEO, spearheaded that, and she engaged the other CEOs of three other large healthcare systems in Detroit. And you can see this picture is a little bit dated. There's someone in the picture who has gone on to other things. You may recognize Mayor Duggan, Mayor of Detroit, in this picture. But as you can see, the top level executives of 4 health systems came together, competing health systems, to work on reducing infant mortality. This effort ended up being handed to Dr. Wisdom. She convened the Detroit Regional Infant Mortality Reduction Task Force, which rolls right off the tongue. But this effort was funded by the 4 health systems, by Kresge, Kellogg, Robert Wood Johnson Foundation, PNC Bank, March of Dimes. Sure I'm missing some, but I think it's all on the slide. And basically we put together $2.6 million to address this issue over a 3-year period. We know it takes longer than that, but this was for starters. And we've had some good news recently that we have gotten additional funds from Kellogg for 3 more years. We're going to be working on this, and March of Dimes is also supporting it. I'm backing up. This is fine. I think we all know that the infant mortality rates in the city of Detroit in particular are similar to some developing countries. And when you break it down by race or ethnicity, you can see that African Americans or blacks in Detroit have more than 2 times the rate in the state of Michigan. So that's why we're addressing this issue. So for this project, we focus on the social determinants of health, and we want to build a supportive network around women in multiple ways. The first is to recruit and train community health workers. In this project, we call them Community Neighborhood Navigators, CNNs, to recruit women, pregnant and non-pregnant women, primarily in 3 Detroit neighborhoods. We also provide healthcare equity training to providers. And then the third piece, which is where the technology comes in, is enhancing all those experiences with technology, social media primarily. So what was the problem? We recruited pregnant women, non-pregnant women, and we had a very strong grassroots effort, a lot of face-to-face contact the first year of the project before we launched our social media effort. We would meet women, the community health workers, I should say, would meet women wherever they were in their neighborhood, sometimes bus stops, laundromats, WIC clinics, other partner sites. We would do great meeting the women face-to-face and engaging them, and then we wouldn't see them again. We would have women who would give us phone numbers that would no longer be good by the time we tried them, or addresses that changed repeatedly because we found a problem of women being couch homeless, meaning that they don't really have a permanent residence and stay in friends' and families' houses. So launching social media actually helped us stay connected to the women that we met face to face. was sort of a solution to a problem. And one of our favorite stories is one of our community neighborhood navigators, Linda, lost contact with a pregnant woman, and she knew she was due, and she tried all of the numbers and the addresses that she had. And she was new to social media herself, and she searched for this woman on Facebook and found her and reconnected with her. She had delivered, and our goal is to stay connected to the women through the first birthday of the child. So this was really exciting and effective. So these are our social media channels. We have a website. We have Facebook, Twitter, Instagram, and it's all branded. And I'll share with you in a moment why it's branded the way it is. People will ask us about texting campaigns, and if we use those, and we hope to, but that never really took off, and there were many hurdles and reasons why it didn't work. There's the National Text for Baby, and we do refer women to that, but we wanted something more localized. It didn't work out. So we do a lot of texting, but not through a text messaging campaign. So before we launched our social media effort, we asked people, women, what they thought, what they wanted, what they needed, and so we did focus groups. And we found that there's no one solution. There has to be multiple efforts, multiple tiers of efforts, types of efforts. So we found in the focus groups a few key things. One is that women get most of their information from other women. Pregnant women go to female family members for information. They also wanted to be empowered. They wanted to hear stories of other women they could relate to who've been through their experience. So with that information, we also rebranded ourselves. We found out through the focus groups that the term "sew up the safety net" did not resonate with women at all. Providers thought it was great. But it's for women, not so much. They didn't get it. They didn't like it. So we rebranded ourselves, and one of our community neighborhood navigators, Nada, came up with the name Women Inspired Neighborhood Network, where women and families thrive. So it's very empowerment focused. And that was also where our logo came in, and the logo has a lot of symbolism, but I won't spend time on that. So regarding our website and our overall strategy, we talk about high tech and high touch. So high touch is face-to-face contact. It's working with humans, developing relationships. We feel that that's, I would say, my key takeaway for this part of the presentation is that all of the technology is wonderful, but without the relationship building, it wouldn't mean anything. It wouldn't work. So our community neighborhood navigators meet with women. They also do use mobile devices a lot. They talk on the phone, they text. We also ask for alternate phone numbers now. We've learned a lot. Some of the traditional outreach that we've done worked, but also didn't work. So we had traditional outreach materials, posters, tear-off pads, community events. We had a series of events called Real Moms of Detroit Expos. But the high-tech part came in afterwards and kept us connected. Also to support members of the families of the pregnant women, aunties, grandmas, friends. They wanted the information too. So that's when we launched our website about a year after the program started. And as you can see, some of our analytics, we've had over 14,000 visits, 36,000 views, page views, and we have almost 11,000 unique visitors. So people seem to be coming back multiple times, and sometimes it's because people move and they want to find resources in their new community. Sometimes someone else in someone's family gets pregnant and they want to get connected. So, and then at the same time that we launched the website, we launched our social media channels, Facebook, Twitter, Instagram. You can see our numbers are a little bit lower, But one of the interesting things about all of this was that we had an intensive training of our community health workers on social media. Most of them had no social media presence, had no knowledge or familiarity with any of it. So they got trained. They were all encouraged to establish their own presence on social media. And then we also had 30-day challenges. And that really moved some traffic to our social media. Once a day for 30 days, someone from our team, Danielle Daggio, who's in the audience, our communication specialist, would send a challenge to the community neighborhood navigators and ask them to get 10 likes among their participants on Facebook, or to post something inspirational, a poem or something like that. And whoever won the challenge at the end of the week got a prize. So that actually seemed to be effective, and the amazing thing is now one of the community neighborhood navigators is live tweeting and really has taken this on and loves it. So I'm going to move on quickly to the next program I want to talk about, Generation with Promise, near and dear to my heart. I've worked on this project since 2007 at the state, and we focus on nutrition, physical activity promotion, and youth leadership. So we're trying to empower youth and families to eat healthier, be more physically active, and to help lead those changes. And we've had funding from Kellogg. Primarily now we're funded through USDA SNAP Ed dollars that come through the state of Michigan and the Michigan Nutrition Network at the Michigan Fitness Foundation, excuse me, and the health system. In the past, we've had other funding sources, and I'll talk a bit more about a CDC REACH grant that we were part of. Last year, we touched more than 20,000 individuals and with more than 50,000 contacts. So again, it's multiple intensive contact. And we've had great results. 88% of adults reported increased fruit and vegetable consumption, and 86% of youth report the same. So we're in schools. We're in elementary, middle, and high schools. We use 5210 messaging as part of our platform. And I wanted to mention, and on your way out the door, there's some materials that I've left. We have a wellness center of excellence called Henry Ford Live Well, and they developed a 5210 Kids app. It's free to download. It's highly interactive, but 5210 is endorsed by the American Academy of Pediatrics, developed in the state of Maine, and we use it in our clinical settings, in schools, and in communities. And it's 5 fruits and vegetables, less than 2 hours of screen time, 1 hour physical activity, and 0 sugar added beverages. And the youth take this and then they educate their peers. This slide I'll be on for probably the longest. Youth wellness ambassadors are another key piece of our project. They're high school students who meet outside of school time. They get trained and then they train their peers or near peers. We had a youth summit recently, only 2 weeks ago, I think, or 3, where all the youth from 14 schools came together, and we taught them about how to develop a success story on iPads. They loaded in photos that they had been taking throughout the school year, and they answered some fields that we had pre-populated about what their plan was, what they did, who they engaged, what their successes were, and a few quotes at the bottom. And at the end, we had 14 success stories, which is a CDC recommended evaluation tool. And we gave those back to the teams to take to their principals to show them. We also created short 2 to 3 minute videos that all the youth helped write and then starred in. That they, again, they talked about things that they did in their school and how they changed the school environment. With the UCLA CDC REACH project that I mentioned, we had some extra funding, and with that we developed toolkits and video accompaniments to the toolkits, which are on our Henry Ford YouTube channel. We also develop digital stories. Those are not posted because they're quite personal, but that's an amazing, amazing tool. we've had challenges because we would love to use social media with our youth to engage other youth, but we cannot do that under the auspices of Henry Ford Health System. So if anyone knows of anywhere in the state or the country where minors are using social media in effective ways within the healthcare environment, we would love to know about you. Our legal department has said that we do not talk to minors. We talk to their parents. And so we have not been able to establish our own social media presence for our project, but we have, in place of that, we've had a more robust web page, and we're trying to engage alumni who are 18 and older to become part of a network. Okay, so the last thing about that is that we had funding to get digital marquees for 2 community partners, and the idea with that is that there would be health promoting messages and maybe challenges where we could get feedback from community members where we would say, text us your responses. Those digital marquees are in process. Lastly, we work at neighborhood farmers markets in Detroit, and with those organizations that have a social media presence are busier. We get people that come and find us because they saw us on social media. We have a fresh prescription program we're going to be piloting this summer, and that we're using technology, iPads, card readers, apps that give us some analytics, some metrics, and we're hoping to do some text messaging in between visits for this as well. And I think that's it for the moment, but if you have any questions, you can reach out to Dr. Wisdom or myself, and thank you so much for your time.
Good afternoon. Today I'm going to do a brief overview of 2 new tools, the MyHealth button and the MyHealth portal, which members of state programs such as Medicaid and the Healthy Michigan Plan can use, which is better, to manage their healthcare information. So they're kind of a set. The MyHealth button is the mobile application. As we've heard today, and as I'm sure most of you know, there's greater access to smartphones than there is to computers, especially in low-income populations like those served by Medicaid and the Healthy Michigan Plan. The MyHealth portal is our online tool, which is accessible via computer. Both contain the same information. They just have a slightly different look and feel for the 2 different mediums. And both are available to current members enrolled in Medicaid, the Healthy Michigan Plan, My Child, and Children's Special Health Care Services, and of course for the children, for the persons who are responsible for their care, such as their parents. Also, the MyHealth button and the MyHealth portal applications interact real-time with CHAMPS and Children's Special Health Care Services using web services, so the information is retrieved and not stored within the applications. This slide gives a list of some of the features that are available through the MyHealth button and the MyHealth portal, reviewing healthcare benefit information, services covered, searching for providers, reporting changes. But the 2 I'm going to talk about in more detail today are the last 2, completing the health risk assessment and the health tracker tool. So embedded within the MyHealth button is it working? Okay, better? All right. Embedded within the tool is the Healthy Michigan Plan Health Risk Assessment, which was legislatively required and which all new members in the Healthy Michigan Plan are encouraged to complete within their, as soon as they can once they get into the new plan that started a year ago. The way that they can do it, they can actually start it over the phone when they first call in to pick a Medicaid health plan, and they can complete the first part of the self-report section of the health risk assessment at that time. And then that information is sent to the portal, and when they first log in, it'll be available to them, and they can then revise it or add to it. There are some additional pieces that they can complete. At that same time, that same information is sent to their Medicaid health plan, so the 2 systems get the same information. Once they complete the self-report parts, and they can either finish what they've already started, and they'll get a message when they come in saying, thanks for starting your health risk assessment, here's where you can finish it. Or if they didn't call in and they haven't started it, they'll get a message just letting them know that this is a place where they can do it. And they can do it through the portal, and this is a slide from the portal, or over the phone. Again, same information, just looks a little different. But once they complete it, they'll get a message saying basically that they need to print it off and take it to their primary care provider. This is kind of the low-tech moment. That face-to-face appointment we know is really important, especially for people who may not have had access to primary care for a long time, may have unmet medical needs. But also it is required to complete the health risk assessment so that the health risk assessment information and that clinical information are shared jointly with the provider and the member to pick the healthy behavior goals that they're going to work on for the following year. And it's making that decision that completes the health risk assessment. So once that appointment happens and they have set those goals, the primary care provider's office then actually submits the health risk assessment to the Medicaid health plan, which then sends it to the state system. Once it's submitted to the state, it will then be present in the portal, and the member has a record that it was completed. But again, this means that the Medicaid health plan and the portal have the same information. The member not only has a record of what they have chosen to work on, and that's valuable to them. It has their information, the provider's information, the goals that they picked for an entire year. It's also a record for them that they completed the health risk assessment, which is important because there are incentives tied to completing the assessment. If someone is a member of the Healthy Michigan Plan and they pay a monthly contribution, they get a 50% reduction. So it gives them a record of that as well. But it's also tied to our health tracker. This is a health tracker like you've all seen that gives them an opportunity to set goals for healthy behaviors like exercise, nutrition, smoking cessation. But this one is linked to their health risk assessment data, and so we'll actually let them know which goals they said they were going to work on with their doctor, and pulls in some of the other information from the health risk assessment for them. And then, of course, it provides them a place to track and monitor the working on the goals that they agreed to set. There's also some healthy measures that they can track, flu shot, blood pressure, things like that. And this is what it looks like on the phone. Again, not only same information, but the two speak to each other. So if they do anything on the phone, they can see it in the portal, vice versa. But the other piece that the tracker offers is not only information about healthy behaviors, why they're important, tips for setting appropriate goals and how to achieve them, but also information about state programs and programs within their Medicaid health plan that are there to assist them in achieving those goals and that they would be eligible for. So this can include information about tobacco quit lines, the referral phone numbers to request transportation assistance for their follow-up appointment that Medicaid health plans offer, the programs to increase access to fruits and vegetables. So trying to help them have another avenue to learn about resources that may be available to them in one place. And the health tracker is actually available to all adult members of Medicaid and the Healthy Michigan Plan. Obviously, they don't have the health risk assessment data coming in because that's Healthy Michigan Plan only. But there is also a feature that's developed from the Michigan Health and Wellness 4x4 plan, which has a lot of the same health priorities and which is available for everyone. So this is actually still quite new. The first notifications that this was available to members went out in late March, and we're quite pleased to see that we got about 2,000 individuals who have registered to use it already in those first weeks without a big media and outreach campaign, although that's certainly in the works. And I don't think it'll be a surprise to anyone that the vast majority of people who have registered to use it have done so through their mobile phones. This continues to be a work in progress. There's a number of functions that are being released just this month, including functionality in Spanish and additional search for providers functions. But more related to the topic of today, in September, there's a planned expansion of the health risk assessment. Currently, the questions are really suited for adults 19 to 64, as are in the Healthy Michigan Plan. So this would expand it for children to be completed by their parents, pregnant women, and seniors. And with that, of course, comes expanded information about programs and services in the health tracker, and also some additional functionality there. So we are continuing to look forward to some new pieces being added to it. Thank you.
All right, good afternoon, and thank you. I'm very happy to be here. My name's Ryan Sullivan. I'm with Michigan Consumers for Healthcare, and we are a coalition of many different consumer advocacy organizations, some of which include AARP, American Cancer Society, the Heart Association, and a number of other organizations you are probably all very familiar with. My message today is going to be a little bit different, and what we're really focusing on from consumer advocates' perspectives, where health IT is concerned, is not just what it can do for us, but what we need to do before it can do that. And so my presentation says no consumer left behind. We've heard this verbiage before with no child left behind. We recognize that before we can actually reach the deliverables that we and the goals that we've set out here and we've talked about so much today, especially with creating consumers who have great degree of self-efficacy, they need to have a great deal of skill and speed to be able to do this. And so do advocates. We have to keep up with an ever-changing world and know where the pitfalls are for consumers to understand and help all of you figure out how we're going to design around some of the things that we can't escape in our society today. They are facts of life. So we think health IT is great. There's no doubt about it. We recognize its importance. But you need the skills and you need the speed in order to do that. And that's not just for the advocates, it's for the consumers. Please pay attention to these stats because they are shocking and they are critical to success. The city of Detroit has a 47% illiteracy rate. That's 3% away from half of the city being unable functionally to read. Think about that just for a moment. In the country, the rate is 14%. 200,000 people in the city of Detroit, and in the United States, 32 million people. And if you think that 32 million people can't make a difference, let's remember that 32 million people is about the number of people that were uninsured before the Affordable Care Act, and we know what that was doing to the dynamics of cost, access, affordability, and everyone's participation in the system essentially being dragged down because we were not bringing everyone along with us. So it's critical as we do this work that everybody can come along, everybody. So when we talk about functional literacy, we are talking about the ability to fill out basic forms, read a prescription, and handle other tasks most of us take for granted every single day. And people will often become very savvy about hiding the fact that they can't do these things. It's critical that we figure out how to identify who can't do these things and link them to the resources that get them to the point where they can. So we talk all the time today about health literacy, computer literacy, health insurance literacy. What's missing in this equation? Well, I just said it, basic functional literacy. We're going all the way back to the drawing board. I want you to forget for a moment everything you've heard today about these incredible programs, and they are incredible. I'm as much a geek about IT as anybody. My background comes from that, and I love it. But without basic functional literacy, for a large number of our population who are, by the way, also driving significant amounts of cost and who are also encountering the system with suboptimal results and re-encountering, we know we have to do something about this. It's one of the biggest health equity challenges we face today. We can't get around this. But the good news is, it's completely solvable. With almost no exceptions, we can teach everybody to read. And there's always ways to do this in a number of environments. It's a matter of connecting people, and it's a matter of getting the numerous resources we have in our society together, working in tandem. And all of you in this room have a role to play in that. Consumer advocates have a role to play in that. And it's not rocket science. We've been teaching people to read for millennia. And we can do it better than ever before. And guess what? IT can help us teach people to read. Computers can now help teach people to read. We do not have to sit with this problem and wonder, gee, how do we figure out how to solve the problem? But we do have to confront it, and we have to admit that it is dragging us down and it is preventing us from getting where we need to go. So, as I said, we know how to do this. It's a question of will. It's a question of conversation, which is why I'm here and why you're here. And it's a question of commitment to continuing to work together and recognizing that where we start is always, for consumer advocates, where the most vulnerable of us are, not where the most capable of us are. Yes, many of us have smartphones. Not everybody has a smartphone. Not everybody has a desktop computer, and not everybody has a high-speed connection. We can't keep blaming our education system for this. It's too late. We can't send people back to school. After a certain point in time, we've got to send people to community literacy centers. We've got to send people to literacy centers established by employers on site. We've got to get people into literacy programs that are hooked up with public services so that when somebody notices that an individual applying for assistance can't read, they are automatically connected to a resource to help them get there. This is possible, and it happens all the time when we design it that way. And remember the cardinal rule of design. When something fails, it's the designer's fault. It is not the fault of the user. And every stakeholder, again, has a role in this process. We can do something about it, but we all have to pull together. I'm going to make another point about accessing all of this great technology and what we can do with it. City of Detroit, almost 40% of households lack broadband internet access, and this includes mobile broadband. So we hear tons about smartphones. Guess what? It's included in that statistic. Smartphones will not save us from this problem. Rural communities are similarly affected by infrastructure, lack of access, and this basic problem of not being able to get on the information highway. The problem is both cost and infrastructure. And again, this country has made commitments to fixing problems like this in the past. We have to do it again. There's no way to get around that if we want to bring everyone into the wake, get us where we need to go with controlling costs, improving outcomes, and getting everybody healthier. This chart, I'm sorry, is a little bit hard to read, but essentially refers to the phenomenon that I just indicated. In Detroit, we are number 2 in the country behind Laredo in terms of broadband access, lack of it. So we've got a really serious problem. And again, it's a question of, do we want to fix it? Not can we fix it? A lot of times as healthcare advocates, consumer advocates, we sit and look at an issue like this and we think, what are the assumptions behind how we're making decisions or failing to make decisions to attack these problems? And I just want to lay some of these out for us to think about as we go along. Age and willingness and ability, both directions. Lots of advocates assuming that seniors, for example, are not going to want to use health IT because they're over the age of 55 or 65. Wherever you make that line, untrue. Not true at all. By the same token, lots of people assuming younger people are necessarily going to automatically engage with this medium. They are not always going to, for the reasons that we saw. Many of them can't read, and they can't afford to access it either. So access and affordability, key questions. Penetration of the technologies. We think everybody has an iPhone. They don't. Mobile is good enough. That's an assumption that we're all starting to get a little too comfortable with, I think. It's not. It can't always do the job that we can when we get broadband access and an actual laptop or desktop. Basic abilities to use these technologies, meaning computer literacy, getting people to the point where they know more than playing a video game or getting on to Facebook. The state of our infrastructure, and again, attitudes toward public access, that we've become incredibly comfortable with the idea that half of a city cannot access basic tools that were the telephone and the electricity of the past. And the potential impacts are that our expectations become based on our assumptions. And we can leave people behind because we start to blame them for their lack of capacity. And that becomes entrenched in the system, and the outcomes start to follow all of that. And that's the most dangerous point that we get to if we don't pay attention to what we've been talking about today. So health IT is great, but we've got to tackle basic functional literacy. We have to improve access to the technology all across the state, rural and in urban areas. We've got to keep the pace manageable so that consumers, especially those most vulnerable and least equipped, can keep up. And we can never, ever, ever forget that there's no substitute for the proper face-to-face, patient-to-provider relationship. This is only an augmentation. Thank you very much. I appreciate it.
All right, thank you to all the panelists. I think we do have some time for a few questions for the panelists, and I think we have a couple lifelines out in the audience as well who may help supplement the panelists. Any questions for our folks? I know it's late in the day. One more session. We're going to keep you awake. Yeah, right up front we have a question here, George.
This question is for Amita. You said there's a service layer behind your portal for the HRA. Has there been any thoughts to opening that up to other parties to put into their portals rather than have, so a member, like let's say I work for Priority Health. Priority Health has a member portal and we want to have somebody go in and update their portal, their HRA, through our portal. Being able to do that interaction with the services layer, has that been considered at all?
Yes, we're definitely thinking about it. I don't know if we want to go into any more detail. Yeah, exactly.
Yeah, there you go. There's your lifeline. Yeah.
I'm Keelie Honsowitz. I'm with DHHS, work with Mita as well on the My Health button. And it's a great question. It's something that we've been thinking about for a while now, but we still are very early in the My Health button, My Health portal. And so we're trying to get through our first releases that get us through September, and then these are definitely the goals that we're looking for in the future for this, not just with the health risk assessments, but all together with portals. We know a lot of health plans have their own portals, and some don't have any portals at all. So we're trying to figure out how can we connect, in the simplest terms, our Medicaid health plans to say how do we work together to do this. So it's definitely something we're thinking about, but we're not quite there yet.
And I didn't plant that question. I was talking to Keelie about this earlier today. So we're working on something on the payer side to help out and complement that. And so that's where we're talking about marrying the two. And instead of that, where you talked about the low tech moment, being able to make that high tech and actually pass that information so it's seamless across all the sections and all the folks that have to touch that HRA. Great. Another question. Yes, we have a question back here. Aaron.
I'm sorry, I don't recall your name, but the beautiful yellow hair. Christian?
Krischa.
Krischa. You showed a cost estimating calculator, and I was curious if that was generated by the claims payment system you're using, or how does that estimator work? Is it real time based on?
Yep, it is real time. Can you hear me? It is real time. It is based upon the adjudication of that claim at that exact moment in time. As with any of these solutions, we weren't able to rely on a singular vendor for that, so we pieced together our core claims system plus a lot of other intel and analytics in our environment to be able to deliver it, but high accuracy on the estimation.
That's amazing. That's
yeah,
really,
thank
really
you.
Cool.
Maybe two more questions if we have them. We got one there and then one over here. Go ahead, Marianne.
I want to go to the issue of literacy, and I'm wondering if you have any examples of communities in Michigan or elsewhere that are addressing this problem, and if there's any best practices that people in this room could look to.
There are a number of different projects that are underway, but I think this is very much something that we need to start. I don't want to say from scratch. We need to look at models that, and the ones that I think of being most successful are workforce development, where people have, and that's actually where one of the statistics came from, was the Detroit Workforce Development Study that looked at where our gaps were in our workforce and how that would hobble our ability to develop our economy in the future. And so what we can do is we can look at analogs in different industries and different sectors, and we can see how collaboration can actually take place. I would say that there are some models around the country that are addressing this literacy issue with respect to the healthcare system, but it's germinal. This is exciting because there's a lot of work to be done, and this is actually the point in time where we can come together and collaborate, and that's why I'd ask anybody who's interested in this to please contact me, because there's so much work to be done here. We can really be a game changer here in Michigan.
So apologies, I think we're actually out of time, so if you can just come on up and talk to the panelists off the stage. Again, thank you to the panelists. Please show your thanks to the panelists, and we'll welcome the physician community up next.